All right, welcome to Boardroom Med. Today we're going to take a look at a step one style question and really unpack it. And today's question is about a child with cystic fibrosis who develops neurologic symptoms. As we go through this question, I want you to pay attention to how we move from the clinical stem to the underlying mechanism and then finally to the answer. And with that, we could read the question here. So, a 6-year-old boy with cystic fibrosis is brought to the physician because of progressive difficulty walking. So, cystic fibrosis, autosomal recessive gene mutation in the CFTR gene. That protein, transmembrane protein, will be stuck in the rough endoplasmic reticulum as a result of this disease. Interesting to know is that cystic fibrosis is not just a lung disease, and that's important to remember for STEP. It causes recurrent lung infections, bronchiectasis, thick mucus, colonization with organisms like especially Staph aureus and Pseudomonas are high yield, but it also affects the pancreas. And in a 6-year-old boy, he also will probably have congenital absence of the vas deferens. But let's continue to take a look. The CFTR mutation causes defective chloride transport in the pancreas. This will lead to thick pancreatic secretions, which can obstruct the pancreatic ducts, leading therefore to pancreatic insufficiency. So that means we won't be able to properly digest and absorb fat. Okay, so when I see cystic fibrosis, one of my automatic thought pathways is, okay, cystic fibrosis, pancreatic insufficiency, fat malabsorption, deficiency of the fat-soluble vitamins. And what vitamins are those? A, D, E, and K. So before I'm even continuing, I'm asking myself, is this question going to test me on one of the fat-soluble vitamins deficiencies? Yes, it is. We already see the answer choices. Okay, so examination shows decreased vibration and position sense, hyporeflexia, truncal ataxia. So this kind of becomes a neuroanatomy question now. It's not just weakness. It's giving us specific neuro findings. Decreased vibration and position sense implicates that the dorsal columns of the spinal cord are involved, right? The dorsal column, medium lemniscus pathway, okay? This is the same pathway that's affected in B12 deficiency, tabes dorsalis, a million other posterior column disorders. Second, we have hyporeflexia. Decreased reflexes often points towards peripheral nerve involvement, lower motor neuron involvement. So we're not just thinking CNS now, we're thinking a peripheral neuropathy component as well. Third, we have truncal ataxia, impaired coordination. This reflects cerebellar, spinocerebellar pathway involvement. Okay? So when you combine these findings with the fat malabsorption because of the cystic fibrosis pancreatic insufficiency, some certain answers should be jumping out. And that what should be jumping out is vitamin E deficiency. But let's keep reading, and the question says that the lab study showed normal B12 and folate. A vitamin E deficiency can clinically resemble a B12 deficiency. It's of note that B12 is not a fat soluble vitamin. B12 is absorbed from the terminal ileum. You need things like intrinsic factors, so something like pernicious anemia could be implicated, but that's not what we have here. Vitamin B12 can cause problems with vibration sense, position sense, gait, neurologic function, but you'll have a megaloblastic anemia as well. You also have increased homocysteine and MMA as well in B12 deficiency. So vitamin E is the answer, and it's one of the nutrients that is understudied. It's a fat-soluble antioxidant. It protects cell membranes from oxidative damage. So tissues with high lipid content, like nerves with myelin, are exposed to oxidative stress. So that's why you have that problem. Another one that has a lot of oxidative stress is red blood cells. So it is common to also see a hemolytic anemia with vitamin E. That's pretty high yield. So vitamin E deficiency, we have posterior column dysfunction, spinocerebellar tract dysfunction, peripheral neuropathy. Now let's connect this to the cystic fibrosis. If you cannot digest fat, you cannot digest fat-soluble vitamins. Patient will develop deficiencies of A, D, E, and K. Okay? Let's go through these other answer choices. Vitamin A deficiency usually causes problems with vision and epithelial differentiation. Key findings are night blindness, squamous metaplasia. Um, if he had difficulty seeing at night or dry eyes, that's vitamin A. Vitamin D deficiency causes impaired calcium and phosphate homeostasis, implicated in rickets on children, osteomalacia in adults. If it was bone pain, bowed legs, fractures, poor mineralization, that's vitamin D. Vitamin E deficiency is our answer. Vitamin K deficiency causes bleeding. That's needed for the gamma carboxylation of the clotting factors produced in the liver, which are 2, 7, 9, 10, and the clotting factor inhibitors proteins C and S. Okay, so if you have bruising, elevated PT, hemorrhage in the setting of fat malabsorption, that's vitamin K. Okay. Vitamin B1 or thiamine. Thiamine deficiency causes Wernicke-Korsakoff and beriberi. Wernicke encephalopathy is confusion, nystagmus, ataxia. Dry beriberi is a peripheral neuropathy as well. And so, but you have to know it's not a fat soluble vitamin. And wet beriberi is high output heart failure plus the symptoms of dry beriberi. Vitamin B6 is wrong, but it can cause a peripheral neuropathy, and it's usually associated with the isoniazid use, which can cause a B6 or pyridoxine deficiency. Isoniazid is part of the right treatment for tuberculosis. There's no tuberculosis here. So when you give isoniazid as part of the right treatment, always give pyridoxine as well. Vitamin K, as we discussed earlier, so that's the wrong answer. So there's our explanation of this question. I'll be back with some more questions soon. Thank you for your time.